Okay, everybody, welcome to part 3 of hematology. This is hematologic neoplasms, which is the cancers section. All right, so let's talk about leukemia. So leukemia is basically a group of cancers that affect the blood and blood-forming tissues, the bone marrow, the lymph system, the spleen. It can occur in all age groups, though you will see that some are more likely in certain areas than others, or certain age groups. Basically, we end up with an accumulation of dysfunctional cells due to the loss of regulation in cell division. So they do not go through apoptosis, becomes fatal if untreated. 29% of all childhood cancers are leukemias. There's really no single cause. Basically, it's a combination of genetic and environmental influences. We talked about oncogenes in our cancer section, and then certainly some chemical agents, chemotherapies, viruses have all been associated with the development of leukemia. So leukemia can be described as either acute or chronic, and we'll talk about that more in a little bit, like the different classifications. So in leukemia, basically we have overgrowth of leukemic white blood cells, and the problem there is that it tends to crowd out other cells, right? So it crowds out the the platelets and the red blood cells, and then our, believe it or not, we can end up with an inadequate number of functional white blood cells. If we have too many white blood cells, we get something called leukostasis. So that's a very life-threatening complication. Basically, if we have a very high white blood cell count in the peripheral blood, greater than 100,000. So that causes the blood to become very viscous and thicken and can cut off circulation to organs and be very life-threatening. So when we have that, when we have leukostasis, we have to treat that immediately. And there are certain medications that we can give that will completely bring that down rather quickly. All right, so to diagnose leukemia, we need to do peripheral blood evaluation and also bone marrow examination, and everything we learned already about bone marrow aspiration applies here. And then we can look outside of the bone marrow. We need to do lumbar punctures and other imaging studies. Our overall goal in the treatment of leukemia is to get remission. Chemotherapy is the mainstay of treatment here. We've talked about chemotherapy under cancer, so I'm not going to go over and over again. Things that you should know, though, is that every time we have to treat the leukemia and it comes back, it becomes less and less favorable to actually be able to cure it or even save the person. Stem cell transplants are pretty common in leukemia because we basically want to ensure that we maintain remission by replacing the person's stem cells. Okay, so this is how we differentiate leukemias, right? Basically, acute versus chronic means the cell maturity at the disease onset. So acute, we have proliferation of immature cells, and chronic, we do have more mature cells that gives us some sort of functionality from them. So most of the time, people with the acute, it's a rather abrupt onset and more insidious with the others. And then we have it based on the type of white blood cell, whether they're coming from the myeloid or lymphocyte line. And we'll spend the next several minutes going over the different types of leukemia that we have. Okay, the first type we're going to learn about is called AML. It's acute myeloid or acute myelogenous leukemia. Basically, 25% of all leukemias are this type of leukemia, so a quarter, and 80% of the acute leukemias in adults. It has a abrupt and dramatic onset, usually with serious infection or abnormal bleeding at the time of diagnosis. It's characterized by uncontrolled proliferation of myeloblasts and hyperplasia of the bone marrow. So the hallmark for this one would be the immature blasts in the bone marrow. So you can see that listed here. Bone pain is a very common sign of leukemias. So you'll see it in here because the bone marrow is being crowded out, which causes pain in the bone. This is one that is a very interesting sign, symptom, which is hyperplasia of the gums. So that's basically how it will look. Let's look at the complications, of course. All right, so bleeding and infection are major cause of death for AML, as are DIC and hemorrhages, once those platelets are, pretty low. White blood cell count of over 100,000, that's glucostasis, which is life-threatening as well. Some of the things we talked about under cancer already. So diseases and opportunistic infections, graft versus host, tumor lysis, and host versus graft. That is basically when a person is rejecting a stem cell transplant. And then something called hepatic sinusoidal obstructive syndrome. That is a very unfortunate syndrome, which we really don't have much of a treatment for. So it's just listed here as a complication, just supportive care. So here's the treatment, right? We have basically induction chemotherapy, and that is an aggressive multi-item chemotherapy. Requires the person to be in the hospital for several weeks, longer than a month often. And basically, it puts the person to be severely pancytopenic. Basically, it pushes the patient to the edge of death to try and kill off all those cancer cells and kind of bring them back. So the treatment of our patients during this time really does revolve around what we've already learned about taking care of a patient who has decreased platelets, decreased hemoglobin, and decreased white blood cells, right? So the treatment is here: packed red blood cells, platelet transfusions, antibiotics, colony stimulating factors. And then after that, the blood counts recover. We look at the person's bone marrow, and if they have remission, we could start some consolidation. And if there's no remission, might do another induction course or go right to the stem cell transplant. The reason that they have to consider consolidation therapy is that if they got remission and then did no other treatment, more likely than not that cancer is coming back. So the stem cell transplant does have its place here. So we'll talk about that. So stem cell transplants, we do get those stem cells from basically bone marrow aspirations, apheresis, umbilical cord, but the question is, do you get enough of them? Why do we use stem cell transplants? Multiple reasons. One, to give a longer remission, even if we can't get a cure from something. Basically, it sometimes is our best and only shot at a cure. There is the National Marrow Donor Program. I encourage anybody who's under the age of 40 to go ahead and see if you would be willing to. You could go to Be the Match on the internet and answer some screening questions, and if you meet criteria, they can send you basically some testing kit at home that you can swab and send it back in, and maybe you'd be a match for somebody. And Some other things about stem cell transplants. Often the person will need immunosuppressive medications following it because of graft versus host disease. Tons of made-for-TV movies about the savior siblings, kids that are born just to save their older sibling with cancer. And then allogenic. So there's different types of stem cell transplants. One is an autologous, which means I give my own stem cells and then they get reinfused back to me. While that may seem great in theory, not the best for leukemias because you may be infusing yourself with cancer again. So allogenic is preferred, right? So less risk of relapse. We don't give ourselves back those cancerous cells. Sometimes people aren't really eligible for a lot of treatment just based on their age and other comorbidities. So if that's the case, then we do have some low-dose meds that we may use, like there's hydroxyurea, same med we talked about under sickle cell anemia. And then I want to refer you back to that cancer section on advanced cancer planning. So sometimes one of the things is that people who have go into this, I'm going to pop us back up here, if they go into induction chemo, if they need to go back into it again, sometimes they refuse to do it, right? They refuse to do it because it's so life-altering, makes them so sick. So sometimes a person may not elect to do that. All right, so the next one we're going to do is chronic myeloid leukemia or chronic myelogenous leukemia. So this one is basically there's too many white blood cells increasing in the blast cells, and the white blood cells, though, are mature. So this is one of the older cancers, right? So it's one that hits the older folks. Oftentimes this is found on a CBC. The issue is if we have far too many white blood cells, then we can get that leukostasis and mess with the perfusion to our brain and our lungs. If there are signs and symptoms, you may see them listed here. They're kind of constitutional symptoms, malaise. So I don't feel well, I'm losing weight, I'm not eating as much, spleen becomes enlarged. It can be painful as the bones get impacted. And for CML, if they get remission, they have less chance of passing away. So they have a pretty good survival, same as the general population. The hallmark for this one is the Philadelphia chromosome. So that's the one to know. It's a genetic marker. It's present in 90 or more of the CML patients. Though not to say this doesn't show up in other ones. It does show up in others, but this is the hallmark of CML. So I think that you should know that. So basically, this is the genetic issue that causes the cancer. So the next thing to know about CML is that there are 3 phases. And the first is that, just so you know, it's based on the percentage of blasts. So the first is the chronic phase, which is the blasts are less than 10%. At this point, if they were to have a stem cell transplant, this would be the best time to do it, best chance of a cure. But we do have a medication now that we use to treat. It's called Gleevec or imatinib. We like these, right? So the Gleevec is basically a medication that was researched and trialed here in Buffalo over at Roswell Park. So we have some hometown pride for that. Basically keeps people in the chronic phase for as long as possible, but makes it very important that that person take their medication as prescribed. When we start to go into transformation, also called the accelerated phase, so don't be confused, they both mean the same thing. Basically, if you have that, then you end up, the person transforms into a blast crisis. And that's right here, right? That's kind of like a middle of the road, and now a blast crisis means that you have 20% more of blasts in the marrow. That should trigger you to know that the acute had greater than 20% blasts. So For this, we will now then go and treat it exactly like the AML, right? Same medications as AML. And then if they go back into the chronic phase, that's what we would want after induction. If they do go into AML, oftentimes the therapy is not that effective in getting them to a second chronic phase. So palliative treatment for CML, basically we just want to get those white cells down, right? We can use hydroxyurea, bisulfan, leukapheresis to immediately decrease those white cells, right? We can suck them out of there, filter them and capture them. And then the medication that I said earlier was one that we might use as daunorubicin. So that is CML in a nutshell. Again, there's more reading in the book. This is just highlights, a little bit of a lecture. So let's go to our acute lymphocytic leukemia. So this is the one that is more for the children. So acute lymphocytic leukemia. The one to know about this is that this one tends to have infiltration into the meninges, so into the brain. So these folks often will need medications, and that would cross the blood-brain barrier, or intrathecal chemo as well. So this is ALL. Management of it. So the management really does rely on the vinca alkaloids and some steroids, a stem cell transplant. So remember those alkaloids, when we're treating cancers with them, they have a high risk of secondary cancers as well. So basically, if they relapse following this, then they go back to induction therapy and then the stem cell transplant. And then here's chronic lymphocytic leukemia. All right, so this one's a little bit different. Remember, they all have something different about them. So this one affects the B lymphocytes. So B lymphocytes are very important. These are basically the basis of our antibodies, are those B lymphocytes. So unlike the ALL, these ones are mature, so the person can fight some infection. Always have lymphocytosis, so always too many white blood cells greater than 100,000. This one has a little bit of a familial component to it, which is unlike the others. And folks who have been exposed to Agent Orange, this one is for them. And then the beta-2 macroglobulin is considered a prognostic marker. So basically, one of the most common leukemias in adults. Complications are rare in early disease, but they can develop as the disease advances. They end up with pain and paralysis from pressure caused by the enlarged lymph nodes, right? So lymphadenopathy can be painful. Mediastinal node involvement can lead to pulmonary symptoms. So for this cancer, it's one of watchful waiting. The folks that are in the early stages generally don't require treatment, but may require treatment as they start to have more and more signs and symptoms. So clinical manifestations really varied, but related to bone marrow failure. So inadequate production of whites, reds, and platelets. But remember, as leukemia progresses, fewer normal blood cells are made. And for chronic lymphocytic leukemia, we concern ourselves with these B symptoms, right? So B symptoms are related to the cytokines, and they show us that there's advanced disease. So what are we looking at? Weight loss, fever, and night sweats. Guys, you have to know what B symptoms are. So overall care of nursing care for leukemia is very much like cancer, right? So making sure that we're watching for neutropenia. Up here it says false negative chest x-ray. Here's the thing. One thing we need to know is that when you have neutropenia, it delays inflammation. So a person could definitely be septic with pneumonia and have a clear chest x-ray. So we want to treat otherwise, right? We're looking for other signs and symptoms. High efficiency HEPA filters. Now, there's some controversy on that. Your book will say one thing, Evolve might say another. They're used in the hospital setting, and some people do have them at home. Comfort measures, Tylenol, sponge baths, changing bed clothes. It's the name of the game, folks. Nutrition. Nutrition is pretty much the same as we're doing with nutrition for cancer care in general. Remember the signs and symptoms that occur because of chemotherapy and what we can do. So here you have it. Take a pause, look at all that. Do you guys know what these mean? Oral care, AC, and PC? Means before meals. And then the psychological care here. Basically, person who gets a diagnosis of cancer, it affects every part of their life. And we've talked about this under the cancer section. So there's truly nothing different here. Pause and reflect on this. Okay, myelodysplastic syndrome is sometimes called a precursor to AML. Basically, if somebody has myelodysplastic syndrome, they are having troubles with their stem cells. So they end up with like problems with the white cells, reds, and the platelets. It's usually a chronic thing. And they make the cells kind of die in the marrow, which leaves little circulating. It's also considered like a form of bone marrow failure. There's two different ways to look at this. One is whether or not the person has low-risk disease or high-risk disease. So low-risk disease, basically we just treat them symptomatically with transfusions. And there, once again, you have iron overload as a problem. And then high-risk disease, the goal is to prevent them from going into AML because that can be deadly. So the meds would be listed there for you as well. So myelodysplastic syndrome. I can tell you if somebody has signs of myelodysplasia, we need a bone marrow biopsy to see what's going on. Okay, so the next little section we're going into are the lymphomas. Won't take you too long, but basically we have Hodgkin's lymphoma. Lymphomas are divided into two groups. One is the Hodgkin lymphoma, and then the other is the non-Hodgkin's lymphoma. So that is everything that's not a Hodgkin goes into non-Hodgkin. All right, so also known as Hodgkin disease, makes up about 10% of all the lymphomas. It has basically it's a cancerous condition with proliferation of abnormal, giant, multinucleated cells. This one, we have the Reed-Sternberg cells. That would be a trigger. If they say Reed-Sternberg, you're going to say, okay, it's a Hodgkin lymphoma. And it proliferates in the lymph nodes. So there's two very specific incidences. You have the younger folks, and then you have those once they get 55. So about 80 to 100 cases a year, a pretty good survival rate, 80% long-term survival for all stages. Really no known cause. We think there's some factors, which would be genetics, Epstein-Barr virus, and exposure to occupational toxins. So this is why our assessment of patients becomes so important. So basically, Hodgkin lymphoma, it starts in a single location and then spreads to adjacent lymphatics. So it has a very, very calculated and pretty much observable spread. Eventually, it can infiltrate other organs. Disease that's above the diaphragm stays confined to the nodes for a variable time, but below the diaphragm often spreads outside to other areas like the livers. Usually has a gradual onset. Starts with enlargement of a single node or area of nodes. Most common would be cervical, axillary, or inguinal. Second most common is the mediastinal node. The nodes are movable and non-tender. They don't cause pain unless they're placing pressure on any adjacent nerves. So what does the patient notice? Weight loss, fatigue and weakness, some B symptoms, fever, chills, night sweats, right? And tachycardia. So those who have B symptoms have a worse prognosis, right? If they're initially diagnosed with those B symptoms. And again, that's a fever, temperature greater than 100.4, 38 degrees Celsius, drenching night sweats, or weight loss that exceeds 10% in 6 months. Interestingly enough, these folks can have alcohol-induced pain at the site of the disease. So think about your young person going out having a drink and they get pain in their lymph node. They could end up with pruritus without any lesions, itchy. Mediastinal node involvement can cause cough and shortness of breath and stridor. In advanced cases, you can end up with hepatomegaly, splenomegaly, anemia. So basically, your signs are going to vary based on location. So our nomenclature is used in staging as A or B classification, and that's basically the presence of systemic symptoms when the disease is found. And then Roman numerals 1 through 4 tells us the location and the extent of the disease. So that's the staging there. The treatment really does focus on, we want to do the least amount of treatment to achieve a cure and maximize our gains but minimize complications. So basically, if they have favorable early stage disease, we get 2 to 4 cycles of these meds, and then unfavorable or advanced anywhere from 4 to 8 cycles. We may use radiation as a supplement, depending on the extent of the disease and any resistance after chemo. There's been a variety of chemotherapy regimens and newer agents used to treat. You can see the one ABVD up there. And once remission's obtained, the curative option may be getting that stem cell transplant. Therapy must be aggressive. And remember that we often encounter life-threatening problems trying to get a cure. There's really not a role for chemotherapy afterwards because after remission, so like how we call that maintenance therapy, there could be a risk of secondary cancers 10 years or longer after treatment of lymphoma. Most common would be lung cancer and breast cancer. And remember, our nursing care does focus on managing problems related to the disease, including pancytopenia and any other effects of the therapy. Next one we're going to talk about is non-Hodgkin. So remember, this is all lymphomas that are not Hodgkin's. It's a broad group. There's over 75 types. And we do categorize them by basically the level of differentiation, like how mature are they, what cells did they come from, how fast are they proliferating, any cell surface markers, any clinical features. Some of the most common ones are diffuse large B cell lymphoma, follicular lymphoma, mantle cell lymphoma. Really no known cause, but we think it can result from some chromosomal abnormalities, infections, environment, and immunodeficiency states, of course. Because they tend to be common in people who have inherited immunodeficiency syndromes, have used immunodeficiency or immunosuppressive agents in the past, or have received chemo or radiation. There's really no hallmark feature to this. It's a widespread disease, usually at the time of diagnosis. Painless lymph node enlargement is the primary thing that we're going to see clinically. And lymphadenopathy can kind of wax and wane. So how do we know if they have like a high or low grade? So high grade lymphomas are those with lymphadenopathy and the B symptoms. Remember what our B symptoms are. We diagnose this much like Hodgkin's lymphoma, but because this non-Hodgkin's is usually outside of the lymph nodes, we often need the extra testing, MRIs, lumbar punctures, like barium enemas. And staging does guide our therapy. So it's very important that we know under the microscope what are we looking at, because that's what we're going to use to treat. In early non-Hodgkin's lymphomas, we may have a normal CBC even. But again, our treatment's guided by the type of cell and the behavior. Is it slow growing or indolent? Is it aggressive? Is it highly aggressive? And the treatment is chemo, biotherapy, radiation, and sometimes phototherapy. Let me move. Oh my gosh, my stuff keeps moving on me. So rituximab is a monoclonal antibody. Monoclonal antibodies are wonderful meds, but they cause a lot of problems with anaphylaxis. So we want to monitor the patient for severe hypersensitivity, especially with the first infusion. And there's your other medications, cyclophosphamide, doxorubicin, vincristine. They may need cranial radiation. One thing we know for non-Hodgkin's, very low chance of survival if they give rituximab or a stem cell transplant and it recurs. Complete remission is uncommon for this disorder, but we can expect to improve the symptoms in a majority of the patients. So a little clinical pearl here is anytime you have something that you can memorize a mnemonic for, probably a good idea. All right, so the next thing that we're going to talk about is multiple myeloma. So multiple myeloma is a condition in which cancerous plasma cells proliferate in the bone marrow and destroy the bone. It's not a large amount of all cancers. It's 1.8% of all cancers. And it's a disease of the elderly, occurring between the ages of 65 and 74. Really not, no known cause, but we think potential exposures to chemicals, herbicides, insecticides, things of that nature, viral infections. So basically, it's a abnormal production of our plasma cells. So normally our plasma cells make immunoglobulins that protect the body, but in this, the plasma cells make a monoclonal antibody, so a single type of antibody that's ineffective and even harmful. That's called the M protein. This disease develops slowly and insidiously. One of the major complaints that a person has is bone pain. It's common that you might have somebody who comes in to your office and they're complaining of back pain. They have diffuse osteoporosis, and you can see these lesions in the skull, vertebrae, long bones, and the ribs. Can lead to compression fractures and pathologic fractures. And then the calcium that's leached out of the bone can cause hypercalcemia, which can lead to problems with your kidneys, can lead to GI problems, neurological things. And too much calcium, the blood is hyperviscous, which can lead to other organ damage as well. So it's diagnosed by the basically the M protein, so in the blood, hypercalcemia. I want you to remember crab. In fact, I want you to remember crab. So elevated calcium, renal insufficiency, anemia, and bone lesions. Diagnosis is based on MRI, PET, CT, and the biopsy, of course, is needed. That is the only true way to diagnose. So how do we treat it? We treat it with steroids, corticosteroids. We can treat it with chemotherapy. We can treat it with immunotherapy, targeted therapy, stem cell transplant, though most people are not candidates for stem cell transplant based on age and other issues. Thalidomide, which was used as an I believe an anti-emetic back in the 70s, caused a whole bunch of problems with the fetuses. And then biphosphonates, right? Those basically prevent the hypercalcemia, push that calcium back into the bones. We may need bracing. Let's take a look here. We may need bracing, adaptive equipment. Here's the deal. Multiple myeloma patients need fluids, right? If we have too much of something, so we have too much M protein, we have too much calcium, our kidneys are screaming for help. At this point, fluids, fluids, fluids. You do not fluid restrict a multiple myeloma patient. So we don't put these people on bed rest, because bed rest just kind of propagates further hypercalcemia, right? It makes the calcium leach out of the bones even more. So they should walk, right? If you don't use it, you lose it. So bed rest not indicated. Keep them moving, but keep them moving safely. This is not a person that you allow your brand new nurse's aide to walk, right? This is a person that you're walking. Monitoring for signs of infection, make sure they have their vaccines. What else can I say? The treatment looks much like any other cancer patient if they're under chemo or radiation. All right, guys, so this one was a little shorter. This was the last section of hematology. Thank you so much.